Morning, everyone, and welcome to the Grand Rounds for the last Monday in April. I have the privilege this morning of introducing our speaker, one of our second-year fellows, Dr. Rob Fraser, who I've had the privilege of working with also on the wards, and appreciate his intellect and his care of patients. Rob is a product of the University of Minnesota Medical School, and from there he went to the University of Colorado for his internal medicine training and spent a year as a hospitalist at the VA Medical Center in Colorado, and then we recruited him to join the Cardiology Fellowship here 2 years ago. Rob and his wife make their home in St. Paul, and they're expecting their second child coming up. And Rob has developed a special interest, I think, in hypertrophic cardiomyopathy because of working in the clinic with John Lesser. So we welcome Rob for his case carousel.
All right, thank you very much, Dr. Sharkey. So today's talk is titled Troponinitis, and this will be a case carousel, and there'll be a unifying theme throughout the cases. We'll see that every patient has an elevated troponin. I don't have any disclosures, and I think this is in many ways some of the true bread and butter general inpatient cardiology. And I say so because as I think back over the last 2 years of fellowship, for all the reasons that I've been asked to consult in patients in the hospital, 3 primary reasons in no particular order seem to be heart failure or pulmonary hypertension, atrial tachyarrhythmias, and then ACS or elevated troponin, the latter of which we'll cover today. And although typically rather straightforward, this can at times be complex, especially when we get into the nomenclature. So we'll jump into our first case. This is a 29-year-old female who presents to an outside Elina emergency room. Her complaint is acute shortness of breath. And so in the process of getting out of the shower in the morning, she has such a difficult time breathing, she yells for her husband to call 911. Upon arrival, she has this ECG and these vital signs. And here we see sinus tachycardia. There's some abnormal ST segments in the inferior leads that don't fit any particular pathognomonic pattern. There's a troponin drawn, and it results at 1.8. Now, shortly after the troponin results, she has a PEA arrest. The emergency room staff perform CPR, they give epinephrine, and they achieve distal pulses. She's transferred to the cath lab for emergent angiography. And here we see a representative shot of her left system that's nearly normal. A representative shot of the right system is also. We don't see these very often, but the interventionalist performs the left PA-gram. You can see extensive clot burden in the left pulmonary artery. And then on the right, we also see extensive clot burden, both occlusive and partially occlusive in the pulmonary. So at this point, she receives TPA. She's placed on VA ECMO and transferred to the ICU. Arrangements are made for her to be transferred to Abbott Northwestern for further care until she's on VA ECMO. She has an echocardiogram done, and somewhat of a rare finding. We see here her RVOT and her pulmonic valve, and there's clearly mobile clots for thrombus at the bifurcation of her PA. So fun imaging, but the point I want to illustrate here is, what do we call the troponin? So for this patient, did she have an NSTEMI? Did she have a type 2 MI? Is this myocardial injury or myocardial necrosis? Is it demand ischemia? Or elevated troponin or troponinemia or maybe troponinitis, like I titled the talk? I think we can all agree we've seen every single one of these terms in various notes at various times. And then not only how are we going to document it, how is it going to be coded? And so today what I'd like to do is work with the 2018 ACC 4th Universal Definition of Myocardial Infarction. We'll talk through WHO ICD-10 codes for elevated troponin, and then we'll apply the two to clinical practice. And so when we look at these two documents and their associated nomenclatures, what we see is that many of the terms that I put up on the prior slides are either not endorsed or not acknowledged. There's certainly some similarities between the nomenclatures, but there's also a little bit of discordance, and that's what we'll get into. So if we first look at the fourth universal definition of myocardial infarction, this was published in 2018 as an update to the 2012 third universal definition. And really, this figure that I've made, it's adapted from both the text and figures within the document. And I think it really gets at the heart of what's trying to be explained, and that is, what is the definition of myocardial infarction? So we start with patients who have positive troponin, and they must have either a rise or a fall. And then we assess them for clinical evidence of ischemia. And this is really left up to the clinician and the clinician's judgment. But typically we're looking at, are there ischemic symptoms? Are there ischemic KG changes? Are there imaging changes or angiographic findings that suggest ischemia? And if so, then you have a myocardial infarction. If you only have a positive component with rise and fall, no clinical evidence of ischemia, then you have what the ACC is calling a myocardial injury. This figure comes directly from the text, and I'm using it just to highlight one point, and that is the concept of chronic myocardial injury, different from acute myocardial injury. And here we often see patients who, yes, have a positive troponin, but it's stable. Sometimes we say the term flat. Check the troponin and it's 0.1, and it's 0.1. The ACC is calling these patients chronic myocardial injury, different from those who have a rise and fall, who are deemed acute injury. This portion of the figure is basically what I showed you on the prior slide. Another nice picture from the document illustrates how many different cardiac and non-cardiac conditions span various diagnoses related to elevated troponin. We take anemia for example, you can have patients who have anemia, and let's use the GI bleed, like gastric ulcer as an example. They may have no troponin, in which case they're out in white space. They may have troponin without clinical evidence of ischemia, and then they're deemed injured in this outer circle. Or they can have troponin with clinical evidence of ischemia, in which case they're in the inner circle. You can see how one condition can span all three circumstances. And the same can obviously be said for hypoxemia, for instance, say a COPD exacerbation, or from shock due to, say, pneumonia. You can either have myocardial injury or myocardial infarction, depending on the presence of ischemia. So once you've made the definition or made the diagnosis of myocardial infarction, the ACC then divides it into 5 subtypes, 1 through 5. Type 1, due to atherosclerosis, you need to have a plaque rupture with associated thrombus. Type 2 is an oxygen supply-demand mismatch, either due to a coronary or non-coronary problem. Type 3 is due to sudden cardiac death. Type 4 is due to PCI, and this actually has 3 subtypes. Type 1, or I should say A, being related to the intervention itself, B, being related to in-stent thrombosis, C, being related to in-stent restenosis. And then type 5 is related to damage. For the most part, focus on types 1 and 2. I think we see them most frequently in practice, acknowledging that type 4 is also common. And so for type 1 MI, again, as illustrated, you really have to have plaque rupture with associated thrombus. Whether it's flow limiting, or I should say whether it's fully occlusive or not, doesn't matter. And then for type 2 myocardial infarction, this is your oxygen supply demand mismatch. These patients may or may not have stable coronary disease, as pictured on the top, bottom. A couple other common causes, a couple other primary coronary causes are vasospasm and spontaneous coronary dissection. Because again, although these are primary coronary problems, they're not related to acute plaque rupture, which makes them type 2 myocardial infarction. So now if we return to our patient, 29-year-old female, again found to have impressive PE. She had this ECG and this troponin. Let's talk through how we define her. So we say she has a rise in troponin. We'd say she had shortness of breath, and I'm not sure that's an ischemic equivalent in this case. She had an abnormal EKG, findings were, I'd say, rather non-specific. It did not show you imaging evidence or angiographic evidence of ischemia. So in this case, she'd probably be called a myocardial injury. You can see how you could easily flex into something like type 2 MI if we were to call those EKG findings ischemia. Or similarly, had I shown you evidence of an RV infarction or an apical fortune. For the time being, we can leave her as myocardial injury. And so now we'll touch briefly on ICD-10. And the International Classification of Diseases is published by the WHO. It's updated every few years. And then it's adapted by most countries around the world for the sake of epidemiological, economic, clinical applications. And within this document, we have the following terms or codes for patients who have health. And so we see under the category of I-21 acute myocardial infarction, we have codes for STEMI, we have a code for NSTEMI, one for type 2 myocardial infarction, this was in US of 2018. And then we also have a code for other myocardial infarction, which is intended to be applied to types 3 through 5 CC documents. And then lastly, there's this code for other specified abnormal plasma proteins. And this is used, or this is defined by simply elevated. So clear, right? I think the easiest way to show this is to take that prior figure and then to overlay the ICD-10. What you see is that if you have a type 1 myocardial infarction, your coding choices are either STEMI or NSTEMI. If you have a type 2 myocardial infarction, there's now a code for type 2 MI. And then if you have a type 3, 4, or 5 myocardial infarction, you're coded as other. Whereas if you have myocardial injury, which is basically your elevated troponin without clinical evidence of ischemia, you're coded as other specified abnormal blood protein. Probably for the most part, it makes sense to document these folks as having elevated troponin to ensure that the coder finds the appropriate code. There's some concern, depending on the institution and the coding algorithms, that myocardial injury may map to myocardial trauma, which is not what we're trying to convey here. It's trying to convey symptomatic elevated troponin. And then I flashed these non-specific terms up here, which we often see in practice in the chart. And they may be fine, but I think surrender some control over what's coded. If you put myocardial infarction, for instance, you're not differentiating whether this is a type 1 or type 2. If you put demand ischemia in talking to a coder, often that's going to map to type 2 MI, but not consistently. And will also sometimes just prompt a coding query. The same is said for myocardial necrosis, troponanemia, and troponinitis, which will often code to elevated troponin, and then this low severity code here. But at other times, we'll just prompt a coding query, and the coders will ask for some more detail as far as what's the clinical circumstance and what's intended by this term. So we'll go through a few cases. First is this 47-year-old female, and she comes in with an hour's worth of chest tightness. She was watching TV, had this sudden substernal chest pain. She's known to have a dilated cardiomyopathy, EF 15% at baseline. She has a dual chamber ICD and a left bundle. She's declined CRT. She's currently homeless and a tobacco user, which is limited her candidacy for advanced therapies. She has this initial ECG. So you can see a left bundle. We also see that there's ST elevation in AVL, ST depression in inferior loops. A few minutes later, with ongoing chest pain, she has this ECG. We now see that there's ST elevation in inferior loops and depression in AVL, and her baseline left bundle. We get the chest X-ray, which shows cardiomegaly in her device, with no acute explanation for her pain. And the third ECG is obtained. Now we're back to ST elevation at AVL with depression and inferior loops. All the while, troponin returns at 0.15. So at this point, the emergency room calls because they can't figure out what's going on with the EKGs. I think what's happened is there's been lead reversal between the left arm and the left leg, And either way you cut it, she's having STEMI. So she goes to the cath lab. Here we see right coronary artery looks pristine. And her left coronary artery looks pristine, although she does have a clear, complete occlusion of this large OM. It's opened with angioplasty, and her pain improves. And so because her coronaries look so normal, aside from the single lesion, she's presumed to have a coronary embolism. The next morning, she gets an echocardiogram contrast, which doesn't show clear evidence of LV thrombus. We can see her troponin trend in the bottom, the peak around 71. She has her device interrogated. There's no evidence of atrial fibrillation, nor had she previously carried the diagnosis of atrial fibrillation. But because of the concern that this was a coronary embolism, she gets a TEE, and this does in fact show left atrial appendix thrombus. And so she started on anticoagulation and does well. So in this woman who had a coronary embolism from her left atrial appendix thrombus without atrial fibrillation, she had a positive troponin. She clearly had symptoms, as well as EKG findings to suggest ischemia. You really only need one, and it's up to the clinician to decide. She's going to be diagnosed with a myocardial infarction. She's then going to cascade to type 2 MI because she did not have plaque rupture. So this is another point where I think there's a little bit of discordance between both the definitions in the universal definition of MI as well as coding, because a lot of us would consider this to be a STEMI by ECG. But according to ICD-10, because there's no plaque rupture, she's a type 2 myocardial infarction. A couple points on coronary embolism. So this group in Japan looked at 2,000 consecutive patients who had elevated troponin myocardial infarction. And they developed some diagnostic criteria for coronary embolism. They found that 52 of the about 2,000 appeared to have a coronary embolism. When they looked at those 52 patients, they saw that about 3/4 had atrial fibrillation, about 1/4 had a cardiomyopathy, 10% had a malignancy, 4% had either septic emboli or an embolism from a DVT through an ASD. It was pretty infrequent, only about 1/3 of patients where they were able to identify an intracardiac source of thrombus or embolism. They didn't necessarily explain what imaging was used. They found that 75% of the time when they were able to identify a source, it was due to left atrial appendix thrombus. So coronary embolism, type 2 MI. Next case is a 54-year-old gentleman. He's coming in with 16 hours of chest pain. He's got hypertension, which is not treated. He's also a smoker. Chest pain's been going on all day, but he's hesitant to come in because he doesn't have insurance and he's worried about cost. He has this initial ECG. This is pretty unremarkable. It shows sinus. There may be some subtle, non-specific ST abnormalities, but I don't think there's anything to hang our hats on. His initial troponin comes back at 40. Again, 16 hours of chest pain. He goes for coronary angiography. Quick shot of his right shows that he gets probably at least moderate disease in the vessel. And then of his left, there's a complete occlusion of the circumflex. This was entirely silent in ECG. It's treated with TCI, and we can now see the distal vessel filling, and he's pain-free. Rather straightforward, acute coronary syndrome. The gentleman had a positive troponin, clear rise. He had symptoms, did not have EKG findings, didn't show you his echo. He had a lateral lump abnormality. So either the symptoms or the imaging findings or his cath would justify the clinical diagnosis of ischemia. So he's going to be a myocardial infarction. He's coded as NSTEMI, type 1. Next case is a 27-year-old female. We're seeing she's coming in after a motor prophylaxis. You see her, and she has no cardiopulmonary symptoms whatsoever. As a part of her trauma battery, she has this ECG. And it's the troponin that prompted the call. And you're asking about her chest and her breathing. All she wants to talk about is her leg pain. You have to be an orthopedist to see that she has a pretty impressive displaced shaft fracture here. So she goes to the operating room. This is fixed. And then gets an echocardiogram. Shows normal biventricular function without wall motion abnormality. Later in her hospitalization, she gets a CTA. Shows no stenosis, no plaque, no anomaly. So here we have a femur fracture. We clearly had a positive component with a rise and a little bit of a fall. But there was no clinical evidence of ischemia whatsoever. So in this case, ECC is going to call her an acute myocardial injury. As I said, it probably makes the most sense to document her as an elevated troponin. And then she's going to be coded other specified abnormal blood proteins. There's some interesting data from just last year in circulation. A group in Edinburgh looked at 2,000 consecutive patients who were admitted with elevated troponin, and they adjudicated their presentations and diagnoses according to the ECC universal definition, or maybe the ESC universal definition rather in this case, and found that major adverse cardiac events looking out 5 years defined as either type 1 myocardial infarction or CV death were the same among all three groups. Whereas then if you look at non-cardiovascular death, highest rates were found in myocardial injury, more so than type 2 MI group, and more so than type 1 MI. Putting all that together in a graph showing survival free from any cause of death, we see again highest mortality in the myocardial injury, more so than the type 2 MI group, more so than the type 1 MI group. So they listed off the top 3 indications for hospitalization in the type 2 MI myocardial injury group, and they were heart failure, pneumonia or sepsis, and lung fracture. I think, as interesting as it is that our patient had a lung bone fracture, this data probably doesn't apply if we look at the mean age of the patient in this type 2 MI myocardial injury group. It was 72 years old, as opposed to 68 in the type 1 MI group. I think you can suspect that probably the long bone fractures were osteoporotic in nature in these patients, as opposed to being due to some kind of freak trauma. It's no problem. A few more cases. 29-year-old female comes in stuttering chest pain. It's been going on for 6 hours. She recently gave birth to a low transverse C-section. Doesn't have any other remarkable history. She has this ECG in 0. This is sinus. T-wave inversions in 4, 5, maybe out to 6. Troponin comes back at 2.4. So in the emergency room, she gets an echocardiogram. Here we see generally normal LV systolic function. And then there appears to be a distal LAD distribution wall motion abnormality. Some severe hypokinesis in distal anterior septum, possibly apex. He goes for coronary angiography. And here we see tapering of the distal LAD consistent with SCAD. So 2 proposed pathophysiologies for this condition. The first is a tear in the intimal lining. You develop a false lumen, and as that false lumen expands, you get compromise in the true lumen, which causes your oxygen supply problem. Alternatively, you can have hematomal formation in the vessel wall due to bleeding of the basal vasorum. And here again, you get compromised true flow. Both these are distinctly different from the concept of plaque as shown at the bottom image. So for these patients, spontaneous coronary artery dissection is an elevated troponin. She did have symptoms. She had EKG changes as well. That's she for imaging changes and angiographic findings. She's going to be a myocardial infarction, and she'll be type 2. Again, because this is not due to plaque rupture. Tear in the intimal The side points on myocardial infarction during pregnancy, looking at women either 1 month up to 3 months post-delivery. We see that about half of these patients have just run-of-the-mill coronary disease, as characterized by stenosis or thrombus in this paper. Another little less than in between a third and a quarter really had dissection. 2% had spasm, 2% had embolus, and then 13% had normal coronaries, which should now be termed no. With type 2 MI for SCAD. 2 more cases. This is a 43-year-old female. She's in the ICU with severe sepsis due to streptococcal pneumonia. She has HIV/AIDS. She's alcohol dependent and has an associated pancytopenia. She's been in the hospital for going on 12 hours, and it's now the evening. The cross-cover intern is called because she's having fluoritic chest. The intern does due diligence and gets a chest X-ray. We see a right lower lobe pneumonia that was present on admission and doesn't necessarily change the circumstance. The ECG is also ordered. Here we see sinus tachycardia. There's definite T-wave inversion or possibly ST depression in most leads. The troponin comes back, initially 0.08, and then follow-up is 0.11. Chest pain is long since resolved, and it was sporadic in nature. So at this point, we could be thinking along the lines of type 2 myocardial infarction. So she didn't necessarily have symptoms. She has probable EKG evidence of ischemia. She signed out to the day team, continues to get antibiotics and fluids. It's an uneventful day. So then the next evening, and there's a new intern on cross-cover who is called for more pleural chest pain. Now, doing due diligence, another ECG is obtained. Here we see things are different. This is still sinus tachycardia. There's loss of R wave progression. It leads B2, B3. There's also some ST elevation, terminal T-wave inversion. When it comes back, it's 163. So you can imagine how the intern felt when she got the call from the lab, right? Value. So she calls the cardiology fellow, and arrangements are made for overnight angiography. Fortunately, just next door, there's a sonographer who obtains these images that thing prior to going to the cath lab. They're not the best pictures, but this was read as severe hypokinesis, all mid and distal segments, that was most pronounced in an LED distribution. So in the cath lab, here we see no obvious lesion in the proximal left. Let's look at the LED, and again, no lesion. These are just representative shots. And all we saw was mild plaque. Looking at the right coronary artery, also just mild plaque. So she's presumed to have a stress cardiomyopathy. She gets an echocardiogram 3 days later. We now see significant improvement in both her LV systolic function as well as her wall motion. So for stress cardiomyopathy, in this case, we had a clear rise in troponin. She had right-sided pleuritic chest pain. I'm not sure that's an ischemic equivalent. She had ECG findings, which, as I stated, could have been suggestive of ischemia. Same with her imaging findings, although her angiogram was normal. So currently, the fourth universal definition, as well as a recent statement from the AHA regarding the NOCA, lists stress cardiomyopathy as myocardial injury, again to be documented as elevated troponin. You can see the similarity between this presentation and that of one with myocardial infarction. So it has been proposed that maybe stress cardiomyopathy is a variant of acute myocardial infarction. We see the similarity in the presentation, EKG findings, and the echocardiographic findings. And it may be that there's either some kind of transient cardiocoronary problem or potentially some microvascular problem, but there do seem quite a few similarities. I'll share with you some data just because it's from this institution. So a few years ago, publishing a series of patients who had stress cardiomyopathy at Abbott Northwestern, 63% of these patients presented with chest pain. Here in the figure, you see that almost all were women, and they seem to have a normal distribution of their ages, around 65 to 70. And the same authors a few years earlier, again looking at the cohort of patients with stress cardiomyopathy at Abbott Northwestern, found that 56% presented ST elevation, another 17% presented T-wave inversion, and 10% healed anterior MI. So taken together, you really have over 8% of patients with stress cardiomyopathy presenting with EKG findings similar to those who have myocardial infarction. In this group, the admission troponin was 4.2, and the peak troponin was 8.4, showing that in our patient, it was in fact a stress cardiomyopathy. She was certainly an outlier. And then more recently published in JACC just last year, not from this institution, looking at long-term outcomes of these patients, comparing ACS to stress cardiomyopathy. We see that mortality is more or less the same, going out 9, 10 years. Then the authors subgrouped the patients according to the cause for the stress cardiomyopathy, and they did find some divergence in the outcomes. So we see here, the purple line suggesting that patients who have emotional stress as a trigger for their stress cardiomyopathy do better than those who have, say, a physical trigger or a neurological trigger. I think this makes intuitive sense because some of these patients are probably dying from the trigger itself, say whether it's some kind of hemorrhagic bleed, whatever it may be. And then we see that there's ACS. Just acknowledging that not all stress cardiomyopathy is created equal. Stress cardiomyopathy for the time being, myocardial injury, but open for discussion. So last case, this is a 52-year-old gentleman. He's coming in 2 different chest pains. So he has a history of autosomal dominant polycystic kidney disease. He had a renal transplant back in 1999 and it's done well. He has CKD3 of that transplanted kidney, as well as hypertension. He's had the expected surgeries. He says that last night while having intercourse, he developed sharp, sudden substernal chest. And that lasted just a matter of minutes and then dissipated and became 1 out of 10 severity. Been there ever since. What actually brings him in is the fact that he's had 2 episodes of this substernal chest heaviness that radiate to his arm and are severe in character. They last about 15 minutes and they resolve without clear provocation. He has this ECG in the emergency room. Here we see sinus, ventricular bigeminy. There's abnormal ST segments in 3, as well as AVF in 1. He's stuck in the emergency room because there's no inpatient beds. His troponins are trended. We see here initially elevated at 0.047, rising to 0.07, and then coming down. He does not have an episode of chest pain. Instrument side that brings 1 out of 10 mild sharpness. He gets a chest X-ray, which is unremarkable. And then because he's stuck in the emergency room, he gets a DQ scan. Again, he has CKD3 of a transplanted kidney. So in an effort to avoid contrast, this is read as low probability for PE. It's recommended that he be admitted and be seen by a cardiologist so that he can be evaluated and potentially get more advanced imaging. He decides to leave against medical advice. Now he's seen in the room 2 days later because he's again had a couple episodes of this chest heaviness. This ECG now shows sinus with ventricular bigeminy. Those abnormal ST segments include AVF and 1 are no longer present. Troponin this time around is undetectable. After admission, he gets an echocardiogram. And so for those of you that either take these pictures or interpret these pictures, there is a subtle abnormality, sorry it's not playing perfectly, that was missed by the initial read. What's not subtle is that there's clearly at least a moderate pericardial effusion and normal biventricular function. Well, being seen by the cardiology service, the patient has a symptomatic run of non-sustained PT. says he's feeling lightheaded, and as we look at the monitor, this is what we see. He's expedited to coronary angiography. The fellow has no problem getting access, but can't find the right coronary artery. So the interventionist takes over. He can't find the right, nor can he find the left. So now a pigtail's placed. This may only play once, I'm sorry. But we see what we thought we were going to see, what we were hoping to see, and that is an aortic dissection. So immediately we call CT surgery, and plans are made to transport the patient to CT and then to the operating room. Now that we've established access into the true, we'll take pictures of the left, which has mild plaque but is otherwise normal. We're still unable to access the right. So here's our CTA. Show us the aortic dissection. We can see that it extends from down near the right coronary cusp up to near the takeoff of the brachiocephalic artery, not involved in the arch. I think this picture very nicely demonstrates how an aortic dissection can cause malperfusion in the coronary artery, which may have been the case in this patient. So to return to that echo, so what was missed was there's this turbulent flow in the root that isn't necessarily well explained. May have just been assumed the artifact and maybe just glanced over. It's definitely non-specific, but it's there. And then in this three-chamber view, which played once and now isn't playing, there's probably what appears to be evidence of flap down the aorta, which when played kind of comes in and out of view and is definitely not obvious. So for this patient who had an aortic dissection, there was clearly a positive component of small rise and fall. He had that substernal heaviness. He didn't necessarily have KG or imaging findings. Because of the symptoms, he'll be a type 2 MI. I just want to take a quick minute to highlight a recent publication by Yader Sandoval. This is just 2 weeks old, published in JACC. Really nice paper. Reviews type 2 myocardial infarction in full, and also covers myocardial injury as well as type 1 MIs. It lays out everything from epidemiology to the diagnostics, treatment, and outcomes of these patients. Excellent illustrations, both in the central illustration as well as others. Special thanks to Yader, who took some time to review my presentation last week. Team up to present today. Much appreciated. So today we covered the 2018 ACC Universal Definition of Myocardial Infarction. We reviewed the ICD-10 codes for elevated troponin, and then we applied the above to clinical practice. In summary, really, if you take the two documents, you get this figure. We could acknowledge that it's pretty easy to flex between diagnoses, then easy to flex between codes. There may be some discrepancies between what we do in clinical practice and what's defined in the guideline or in coding. For instance, the lack of ST elevation is a code for patients who have type 2 MI. But nonetheless, we can acknowledge that. That's all I have. Thank you very much.
The overhead mics are on if you have questions, so go ahead.
Yeah, Rob, fantastic. Thank you. Very coherent. I was sitting next to Dr. Sharkey, who was up there, and we're having a hard time understanding the troponin of 162 with Sharkey syndrome.
I know.
So I was wondering if you had a thought on that and if Dr. Sharkey had a thought.
So I'd be curious to know what Dr. Sharkey thinks. I think alternatives without having done more advanced imaging, some kind of myocarditis. There clearly could have been some kind of transient epicardial coronary phenomenon, whether it's spasm or thrombus and canalization. Not known. And I think to Dr. Sharkey's point in this paper, these often behave like stunned myocardium. So in retrospect, it's difficult to tell because there's improvements in the systolic function. It could be due to stress cardiomyopathy, or it could be due to that stunning.
Well, John and I were both struck by that. The troponin of 182, I've not seen that in a Takotsubo case. The other thing I would point out to you is the first EKG you showed widespread ST segment depression. And that's very unusual in Takotsubo. It's almost always ischemia from coronary events. And I would submit that the angiogram on that patient was, I'd have to study it, and I'd certainly want an MRI because I think you would see definite tissue necrosis.
Sure.
But your talk really brings up a good point, Rob, in terms of this whole diagnosis of infarction, because infarction is really a pathologic diagnosis. It's tissue necrosis caused by inadequate blood flow. And so we've kind of taken troponin to equate it to tissue necrosis, but often without any documentation that that's the case. And for example, that pulmonary embolism case you showed, who knows what that is? Like you pointed out, are there cells that are dying or they're just stressed? Because you can get significant troponin elevation by running a marathon and with totally normal coronary arteries. So this whole concept of infarction versus troponin elevation, to me, has yet to be worked out. And the other thing that you point out is what represents a change in troponin? Is 0.04 to 0.07, is that a change, or is it biologic variability? So those are also issues to
I hate to get into that
consider.
explicitly, but I believe in the definition it's greater than 20% variation.
But that's just someone's opinion.
Totally.
That's Alan Jaffe's opinion, and I respect him a lot, but it's still opinion. So.
Yeah.
Hey, Rob, good job. I do have a question regarding that case with the patient with non-ischemic cardiomyopathy and coronary embolism. So this guide me down a clinical path of how you typically work this. So this patient was defined as no atrial fibrillation at all, right?
Right.
In the ICD interrogation.
By device, yeah.
And then the echo shows, the echo with contrast, so there's no thrombus. So typically, under me, I would say, okay, the next step I would do cardiac MR to make sure there's actually no LV thrombus. So how many of these patients will you actually do a TEE? Because that was a complete surprise to me.
It was a surprise to me, frankly. And so I think in most cases, yes, you would do an MR, verify there's no LV thrombus, and that would be your number one suspicion, even with the contrasted echo. But staff's opinion in this case just led us to do a TEE.
Yeah.
The capability for non-formal MRI, conditional MRI imaging at Hennepin is not the same as it is here. So that also pushed us to do whatever additional imaging is available, readily available, for the TE.
Do you think most of these patients we should, because maybe I'm not doing it right, should we do TE on a lot of these patients?
I don't necessarily think so. I'm curious to know what Dr. Sinkla thinks. From someone who has such a profound cardiomyopathy, LV that's in the order of 6.5 to 7 centimeters, yeah, certainly less than 15%, they're probably at more risk than the patients that have 35 or 40% of events like this. But, I wouldn't think that necessarily everyone should get that sort of thing.
We did go through a run of these and trying to make the diagnosis with elevated troponin and no obvious coronary etiology. And we used to do TEEs looking for an atrial level shunt. And the yield was very, very low. There was a couple, and we also did hypercoagulable workups, and the yield was the same as the general population, essentially.
And sorry, just quickly, is that when you compare echo with contrast versus MR, what we have found, at least the study has found, is that it's essentially MRI without contrast. And really the key to see thrombosis with contrast. So.
Yeah.
I have a question on troponins. How many should we do once it's positive? Should we use it like a pregnancy test, i.e. positive or negative? Or if it's positive, should we continue to check?
I don't think I'm necessarily the expert to answer that question. My opinion would be order a test if you think it's going to change the treatment. So once you see that there's an abnormality, unless it's going to change what you're going to do next, it's probably not worth trending it. I think probably at least 2 values are helpful to get a trend. Beyond that, I think less is probably added. Although you look at the patient who had the stress cardiomyopathy, cross cover into. We got another troponin for pleuritic chest pain. In that case, it sure wasn't insightful. Yeah,
I wonder what the ICD coding on those patients actually was. That you didn't go look at it.
I didn't know. Good question.
Do you have any sense of that?
Well, I think just to make it, this was a fantastic talk. I just want to say that first off, and will be useful for you as you continue in your career and have to speak to lots of people about what does this mean, because as we move into an era of high sensitivity troponin, it's only going to become more prevalent. The thing to keep in mind is, although you're talking about mapping of ICDs for the troponin, there still are specific ICDs for coronary dissection, for stress cardiomyopathy,
Yes.
so just to keep in mind so that people don't say, oh, I just need to talk about
Yeah.
the troponin. And the other thing is to recognize that the variability on this coding is insane, right? Like this isn't epidemiologic quality data. You're going to hang your head on it.
No, that's why I was curious to see how these were actually coded.
No, I'm sure it's all over the place.
So that's an important point. So there is a code for stress cardiomyopathy. There is a code for dissection.
And you might,
But not
as
not
you're speaking to non-cardiology audiences, I think it would be important to recognize that they should also be talking about.
Right.